Welcome everyone. Welcome to the Hopkins Bloomberg Center. We're really excited to have everyone here. We'll put these blinds up in a little while when the sun goes up and then you can see the Capitol. But yeah, I think we have a great lineup and we're really excited for the panel later today. So we'll talk about some ground rules at the break. We're gonna have coffee all day in the back and we'll have lunch back there as well. So I think what I'd like to do to start is our Vice Dean for Research, Gokar Aiden, is going to speak and get us started for a couple of minutes.
Good morning, everyone. It is my absolute privilege to welcome to Hopkins Bloomberg Center for the speech. I'll start by thanking our co-sponsors too, of course, the Boyd Center at the University of Tennessee and STATA. Last but not least, Hopkins Business of Health Initiative. I'll say a few words about Business of Health at Carey and Hopkins because I think it's useful maybe to give you a little bit of that landscape. So we have about 120 faculty members at Carey Business School, and more than a quarter of them would say that healthcare is one of their primary interests. And these folks range from, in their academic disciplines, marketing, management and organization, information systems, law and ethics, operations, and of course, econ. We are blessed with having wonderful health economists at Carey who drive forward a lot of impactful research. And the Hopkins Business of Health Initiative is a large part of that too. So Hopkins Business of Health Initiative, led by Dan Polsky, brings together scholars from Carey Business School, School of Public Health, School of Medicine, and School of Nursing. And with that kind of diverse approach to research and practice, of course, it provides an incredible platform to do work that's really impactful on policy and practice. So we're really grateful to Dan Polsky also for all the work he does through the Hopkins Business of Health Initiative. Last but not least, I want to say we're also grateful for this wonderful facility. Of course, our first home is in Baltimore. That puts us in close proximity to everything that Hopkins does in healthcare. But this second home has been wonderful for us for the second year now. A good manifestation of that is the panel that Michael is hosting at 4 p.m. today, moderating with participation from Congressional Budget Office, Center for Medicare Services, Health and Human Services, Brookings Institute. That's the kind of interaction that we have been really blessed to have through this center. So I hope you enjoy the day and you hope you enjoy this facility as much as we do. I also want to say thank you last to Michael for all his efforts in putting this together. And Liana Watson also on the Hopkins side has been working very hard on this. So thank you for that. And have a great day. Thanks, Gary.
Okay, so for the first paper of the day, Melissa Garrido will present parallel trends and unparalleled pandemic differences for infectious disease policy evaluation.
Hey, everybody. All right, it is my pleasure today to present this great paper by Feng and Bilinski on parallel trends in an unparalleled pandemic. Normal disclaimer, I don't have anything to disclose. All my opinions about diff and diff are mine. None of my institutions care. So I'll obviously go into more detail, but just as a brief overview of what the contribution of this paper is, they talk about the difference in difference models require an assumption of parallel trends. And in analyses involving disease transmission, they highlight the conditions that are needed to meet that parallel trend assumption vary quite a bit with diff and diff specification. So thinking about modeling incidence versus log growth, for example. They also introduce a couple of different specifications, log effective reproduction rate and the log contact rate, that require weaker assumptions than specifications that we normally see in applied analyses. And Importantly, they also provide practical advice on the power and feasibility of using the different specifications, which I really appreciated. So we have our canonical diff and diff set up just to kind of orient everybody. We've got the 2 time periods, the 2 groups. And the idea is that we are relying on a parallel trends assumption. So in the absence of treatment, the treated group would evolve in parallel with the comparison group. But because we can't actually observe both potential outcomes for the treated individuals, we rely on the estimated average treatment effect on the treated, looking at differences in pre to post outcomes between the treatment and the comparison groups. So increasingly, there's been a recognition that parallel trends assumptions are usually sensitive to functional form. We see this mostly recognized in comparisons of untransformed versus log transformed outcomes. So just because pre-trends in incidence are parallel, that doesn't mean that pre-trends in log incidence will be parallel, for example. And in fact, recent work from Roth and Santana show that the parallel trends assumption is only insensitive to functional form, meaning that the parallel trends hold for monotonic transformations of the outcome variable in really specific circumstances. So either the treatment has to be as if randomly assigned, or the distribution of untreated potential outcomes is stable over time for all groups, or a hybrid of those 2 situations. So as you can imagine, these circumstances don't really apply to many real world settings, particularly in the case of infectious disease transmission. We have exponential spread of many infections. So for instance, a policy that's intended to mitigate the spread of a disease is going to be implemented in response to elevated transmission or incidence rates. It's not going to be random. And similarly, untreated potential outcomes, if you're thinking of disease incidence as the outcome, those are going to vary with time naturally as the infection spreads. What the authors do is they point out that in applied work, the importance of this functional form of the outcome is under-recognized. They do a nice survey of the literature, catalog how often individuals are even talking about the functional form of the outcome. So there's really this implicit assumption that outcomes are evolving linearly over time. So in recognition of this, there's been calls both from the authors of this paper and from others for greater attention to the data generating processes underlying diff and diff models. In particular, if there are different pre-treatment levels of an outcome across treatment and comparison groups, which we usually think is just fine in a diff and diff setup, we need to really pay greater attention to the reasons for differences in the levels. So if the differences in the levels are influenced by the same mechanism that might be influencing trends, it might really be difficult to satisfy the parallel trends assumption. And so infectious disease transmission is really a useful framework for studying these issues because it is often exponential in transmission. So say you have an infectious disease that has different numbers of infections per 1,000 residents in both the treatment and the comparison groups. Those differences in levels mean that there are different numbers of susceptible populations in both the treatment and the comparison groups. So without any type of treatment, the treatment and control groups are going to evolve to have different numbers of infected individuals. Actually, some of these issues were outlined in a paper by Callaway and Lee that was highlighted at a pandemic era AQs. This is a nice continuation of some of that work. So the new contributions here, Feng and Bilinski really dig into these issues. They catalog the epidemiologic assumptions that are required for diff and diff to produce unbiased treatment effects when the data generating process is following a susceptible infectious recovered model. They introduce these new specifications based on reproduction rate and contact rate, and then they evaluate the trade-offs of model choices. All right, so now for a little bit of epidemiology at our econometrics conference, want to give everybody some definitions of the components of FIR models. So these are Markov models where incidence is a function of the effective contact rate, so that's beta. It's also a function of the size of the infected population, and the fraction of susceptible individuals. The susceptible population at time t+1 is simply the number of that were susceptible at time t minus the number with an incident infection at time t. And then the number that are infectious at t+1, so this relates to the prevalence of an infection, depends on gamma, and the inverse of gamma is the average length of the infection period. Recovery also depends on gamma. So in these models, we often assume a Poisson distribution. You can use other distributions as well. And two other common assumptions are that there is an infinite susceptible population, so that the fraction of susceptible individuals is not a concern. And then there's also homogeneous mixing, so that the contact rates, interaction with infectious individuals is constant. So back to our canonical diff setup, I want to draw your attention just to the bottom line of the slide here. So we're extending parallel trends to monotonic transformations through a link function. And in the remainder of the paper, the authors vary the outcome specification and the link function to illustrate the conditions that must be true for parallel trends to hold. So using this SIR model really helps illustrate the embedded assumptions in a different analysis, because there are assumptions that you're going to see will vary about the susceptible population, about the initial incidence, and the effective contact rate, the probability of transmission when contact occurs. One other concept to be aware of is non-trivial susceptible depletion. So this happens if transmission is extreme or if there is a small susceptible population. So the authors examined 5 different model specifications. The first 3, incidence, log incidence, and log growth, are commonly used in applied literature. And the second 2 are new to this paper in terms of a diff context. So the R sub T there refers to reproduction and not recovery, as it did on the previous slide. It appears that R is used in both cases in epidemiology. That can confuse me for a minute, but there's a footnote that explains it. And we heard a lot about the R value during the height of the pandemic. So if R is less than 1, incident infections are declining over time. And then beta is the contact rate that we saw in the SIR slide. So diff and diff with incidence, this is really common in applied analyses. Here, the average treatment effect on the treated is just the difference in incidence over time. But this requires really strong assumptions in order for parallel trends to hold. So the susceptible population either has to be equal across treatment and comparison groups, or we need an infinite susceptible population. We need initial incidence to be equal across treatment and control groups. And we need the effective contact rates to be equal across treatment and control groups. These are very strict assumptions that are unlikely to occur in real life. So thinking about COVID for a moment, you can think about how initial incidence and contact rates are likely higher in the groups of states and counties that are subjected to infection control policies. So right away, that raises some flags about using the incidence as a specification. And with many thanks to Dr. Bilinski for sharing slides that illustrate the results, here's another way of looking at the impact of assumptions. So with incidence, we only see parallel trends when all of the parameters match each other. So that's the panel A on the left-hand side slide there. You can also see the impact of different initial levels, which again, we don't normally worry about in this setting in panel B. See, we already don't have parallel pre-trends. So the next specification they look at is log incidence and estimating the percentage difference over time. So here we have weaker assumptions that are required. In particular, we no longer need initial incidence to be similar across the treatment and control groups. And now you can see that we have parallel trends, even if there are different pre-treatment levels. However, contact or transmission rates still need to be equal to have parallel trends. Alright, so what about log growth? What if we look at the increase in incidence from time t-1 to time t, focusing again on a percentage change? And the assumptions again are a bit weaker. Now instead of needing equal contact rates, a constant ratio will work as long as gamma equals 1. So that means that the infection period lasts as long as the time step. So people who are infectious at time t recover by time t plus 1. If you meet all of those conditions, then you see parallel trends in many more situations, so over different transmission, different time varying transmission. But you'll see on the far right panel, in panel E, the specification is not robust to non-trivial susceptible depletion. So new in this paper is a suggestion to model the log reproduction rate. So reproduction is a function of gamma, so the length of infection, beta, the contact rate, and the fraction of the population that is susceptible. And when you use the log of the effective reproduction rate, you no longer need the infection period to equal the time step. You just need the constant ratio of transmission rates between the treatment and comparison groups. So similar to log growth, we see parallel trends when we have different initial levels, different transmission rates, and different time varying transmission. But also, like with log growth, if susceptible depletion is affecting the treatment and control groups in different ways, you're no longer going to have parallel trends. And then the final specification they introduced is the log effective contact rate. So this is the beta that's in the equation for the reproduction rate and for the incidence. This has the fewest required assumptions. So we no longer need to assume an infinite susceptible population. We do still need a constant ratio of transmission rates across groups. And in this specification, we see parallel trends across all of the different scenarios that they discuss, even in the case of differential non-trivial susceptible depletion. So both the reproduction rate and the contact rate, they require weaker assumptions, and they can be estimated based on maximum likelihood estimation following an SIR data generating process, or we could use an extended model, perhaps one that separately accounts for exposed individuals. These values can also accommodate heterogeneity across subgroups and individuals. And just briefly, I'll note that the authors have already considered many other extensions. So one of them is time step aggregation, so aggregating weeks into months, for example. And in that case, you need an aggregate parallel trends assumption. And they also can extend this work to multiple units and time periods, including in cases of staggered treatment adoption. So in addition to cataloging the assumptions needed for parallel trends to be true and deriving these situations, the authors evaluate the trade-offs that are involved in each specification. So they conducted a simulation study to evaluate the power of each of these specifications across different contact rates, population rates, and magnitude of treatment effect. So the y-axis here is the probability of rejecting the null hypothesis. The x-axis is the effect size. And you can see that incidence and log incidence have similar power. Both of these have better power than log growth. And then log contact rate, which is the only specification that is robust to depletion, has better power than the other alternatives that require weaker assumptions than incidence and log incidence. So they also do a nice job of demonstrating the implications of outcome specification in applied analyses. So they reanalyzed data from two studies. One was a staggered diff and diff study in NEJM that looked at the effect of district level mask policies on weekly COVID cases per 1,000 individuals. And then they extend the incidence model that was used by the authors to log incidence and log growth. The other was a study of county level mask mandate adoption on daily COVID rates in Kansas, and that's where the graph on the screen is from. And the authors extended this study to all of the specifications they outline. So this is a bit small because it's just a screenshot of the table, but the thing I want you to really note is the really wide confidence intervals around log growth, so the third row of outcomes in each of these instances. So depending on the specification, this significance might be lost. In some cases, the direction of the average marginal effect changed. So this really highlights the importance of thinking through the assumptions underlying a different diff model and thinking about the data generating process that might be at play. So before I move to my comments, I just want to summarize the author's recommendations. The first is to use log incidence rather than instance if you're choosing between the two. Log incidence is slightly more flexible, so it allows for those different initial levels, and it has similar power. Of the three more flexible models, log growth has the worst power. Log contact rate is the most flexible and it has better power than log growth. And log contact rate is the only one that was robust to different levels of susceptible depletion. And so I really like this paper, so I have, you know, some questions about ways to make the implications maybe clearer for individuals applying these methods who might not think about an SIR model on a day-to-day basis. Some hopes and dreams about time varying confounding, potential extensions, and I'll go through each of these. But really, this is an important contribution to a growing literature on the nuances of parallel trends assumptions, and the focus on power and feasibility in real-world analyses is really appreciated. So one thing I was curious about as I was reading this is how this might fit into some other work on using diff and diff to model transitions. So John Graves, Laura Hatfield, and colleagues have done some work related to scale dependence in diff and diff. And they use categorical outcomes to illustrate challenges in interpreting parallel trends assumptions. They use the example of insurance coverage. So people are switching in and out of different coverage categories. And in this case, a variety of different situations could be leading to parallel trends. Maybe nobody's changing categories. Maybe the number of people who are leaving one category is equivalent to the number who are entering that category, and you still see flat lines. And in that work, they're also assuming that transitions follow a Markov process. So one suggestion going forward would be to generalize this work even further. So the SIR model, I think, is really great for illustrating the points, but I think there's even broader implications beyond what has been highlighted. My other question was about time varying confounding. So the new specifications that are outlined are robust to factors that are part of the SIR data generating process. And I'm hoping, I think overly optimistically, that there's something about them that could protect against or minimize the impact of other time varying confounders. So what I'm thinking of is a case where we might be evaluating the impact of a policy on disease incidence. But we know that disease incidence influences things like availability of health services or healthcare workers. So the impact of that insufficient workforce on health outcomes might also grow over time, and then confound analyses of the impact of a policy on incidence. I'd also love to hear more about how these specifications may or may not interact with synthetic control or synthetic diff models. And then, again, I really appreciate the focus on the power and the feasibility of using the different approaches, but I suggest extending this even further. Something I do in my day-to-day work is work on tutorial manuscripts, and there are a lot of things that maybe those of us in the room assume are true that most people out in the field aren't really aware of. So just thinking about concrete recommendations you might be able to give about how often is an infinite susceptible population a reasonable assumption? When is aggregation over units of time or geographic areas a good or a bad idea? And some of this is touched on in the paper, but I think it can come out even more. I was also curious about what are the practical implications of applying these kinds of models to infections that have oscillating transmission rates? Do people need to shorten the time period included in the analysis? Is there a different data generating process they might use? So some of those things that myself, not an epidemiologist, I haven't thought through deeply, but I think would be ways to make sure people are paying attention to these really important nuances. And I will stop there. Thank you.
Got about 10 minutes. Next question.
Great. First, I want to thank the discussant for such an amazing overview going through. It's actually a very in-depth going through of the paper discussion, and I really appreciate all the valuable comments for going forward. And to start sort of in the response to the comments, I want to first answer the question of where do we come from? Like why did we ever care about this, and what motivated us to do work into this question? So as we all know, like definitive has been one of the most popular method, or sometimes the most popular method in all kinds of policy evaluation. And it has become even more popular during the pandemic. And as the discussion mentioned, that there was a lot of disagreement on how to use DID to evaluate COVID-19 incidence mortality. And for that, I'm thinking about like what outcome you are plugging in into the difference model, and that can be instance log, growth log models. And as Rolf and Santana pointed out, that the parallel chain assumption is usually sensitive to functional forms unless under those very strict conditions. So that gets to the central question of why do we even trust that parallel, like the trends will be parallel when the levels are not, right? And definitive is appealing because it allows researchers to do treatment effect estimation, even when we don't have a comparison group that's perfectly matching the treatment group. But it's very hard to understand what the parallel chain assumption confers about the underlying data generating process. And on that, that's where we started to thinking about infectious disease theory. One, because that outcome has a quasi-exponential growth rate that is a lot more publishing than many commonly used growth types. So traditionally, we think definitive works well when we have a slowly evolving outcome or sort of the linearly growing outcome. And prior work have extended that to additive and multiplicative assumptions under which that parallel chain assumption will hold. However, what we're trying to say here is like, if we're dealing with infectious disease outcomes, that's exponential growth and nowhere close to something we say a linear or slowly changing. But the good things about that is it has a sufficiently deep theory that allow us to precisely interpret the parallel chain assumption that is mathematically tractable. So we think about the world of DID or the world of observational causal inference and the world of infectious disease modeling. Of course, both of them have their own benefits and drawbacks. I'm not going to the detail of this. A lot of them has been covered by the awesome discussion already. But the highlight of our work is we wanted to take the best of the both worlds and to answer the question that what must we assume about the treatment and comparison transmission dynamics for different DID specification to work well. And for that, we formalized assumption of different specifications from an active perspective. And that's where we bring in the SIR model. And in just a little bit, I will also talk about the extensions to the SIR model that we could think about. So first of all, like we propose to use the log beta T model. So in addition to those simulation results or the practical examples that you just saw, we argue that log beta is more flexible than the other commonly used specification. And it does offer protection against the time very confounding in the other levels, e.g. cases. One example that you can think about is like successful depletion, right? That's something is going to happen anyway, and that could be time very confounding, and that's something, some protection that using a log beta model is going to buy you. And it also allows transmission rates to oscillate as long as the trends stay parallel. If we think about modeling a flu season, right, that has a lot of seasonality going up and down. If we're looking at, for example, a case instance scale, they're going to explode up anyway, right? It's just like at different exponential rates. And it's so hard to track or think about how you can make trends parallel where you have varying oscillating transmission rates there. But if we're through the scale or the length of a beta t or the effective contact number view, then as long as the trends are stable, the oscillating transmission rate is not a problem. But here you might ask the questions like, okay, I'm not an epidemiologist. Why, like, what's beta t? Where do we get there? And why do we ever want to think about this quantity? Help me think about this quantity. So we argue that beta t is actually an intuitive quantity to use, and it's linear in many kinds of policy impact. And that's why it could be a good fit into the definitive framework. So just a little bit of math for now, like under some conditions, we can write beta t as a function of the probability of becoming infected given infection's contact multiplied by the number of contacts. And in this sense, so if we think about many like containment policy, for example, that reduces contact rate in one place by 50% and cut the contact rate in another place by 10%. Given this formulation, the beta t is still going to be parallel between those cities or these places, but that's not going to happen in any of the other scales. So that's why we love beta t, like we know a lot about it, we know how to formulate it, and we know that it fits a lot into the linear structure of the DID model. Yeah, so going into the extensions, there are, of course, a lot of the infectious disease data-generating process as the discussant has highlighted. And log RT and log beta D, the two specifications that we proposed, they could be easily extended to any other data-generating processes as long as these quantities are well defined. So I will give an example of one ongoing project with Chai, where we are trying to evaluate the malaria control efforts. And that's a picture of sort of how complicated it can get for a infection disease transmission dynamic. And from our perspective, you don't need to care about a lot about how things are transitioning from one to another, as long as at the end of the day, it has a reasonable or it has a reliable definition of the effective contact rate or the beta D parameter. And we know that that's something that's stable, relatively stable over time and linear in the sense, we will be able to plug that into the DID estimator and gives us all the good advantages that comes out of the log beta D specification. Of course, there are many alternative causal inference methods. Synthetic control is one that I discussed mentioned, regression discontinuity and ways to deal with spillovers as well. I also highlighted SM here because that's something that we are also actively working on right now. So if you think about that, that has an idea that's quite similar to definitive, right? We're taking now a weighted average of the control units and trying to reproduce a counterfactual for the treated outcomes. And that still happens in a weighted linear sense. And if you are trying to replicate an exponentially growing outcome, that's not going to work. The problem still persists. And on that, we are also looking at what happens when we have a mix of good units and bad units. What will mess up your estimation in the synthetic control method. And finally, I just want to talk a little bit about uncertainty. So if we always require a p-value less than 0.05 to make a decision, it will be extremely hard to act in reality, especially in the sense when we in the practical example that we see these super wide confidence intervals. And that would say like we will not act at all times. And by doing that, that's already a decision that's being made. So instead, there are different ways to think about that. For example, the decision analytic framework for quantifying the uncertainties related to the benefits and then the cost of that action. And that can help us inform decision making. So thank you. I think that's all I have. Yeah, that's a cake my co-author, my advisor, Dr. Bilinski make. That's a very great cake. We have a lot of sweet treats during my time. So thanks.
Got about 10 minutes for questions. So we'll see if we can run a microphone around. If not, we say it very loudly.
A very good paper. So suggestion. Question is, beta T, obviously, as you said, is not observed in the data, right? It has to be estimated, and so wouldn't the estimation error create some additional issues of then establishing policy effect with a parallel trend assumption? Like, especially if the estimation error is actually probably as more individuals accumulate, would probably go down over time, or it might increase. I mean, it depends on how the model works. And so I think I'm trying to figure out how to do a DID with something that is not observed, right? The other thing which kind of bothers me here, which is, again, this is a great paper in understanding the actual parameters that leads to unparalleled trend. But if we think about from an event study perspective, if you observe parallel trends in incidence for a long time, can we infer that the underlying parameters are the same? I'm trying to figure out that, yes, if the underlying parameters are not the same, incidence the trends kind of deviate, right? But if I observe parallel trends in the incidence, how many panels do I need to infer that the underlying parameters are the same? I mean, I think that would be quite useful to understand.
Yeah, thank you so much for the question. Those are very valuable thoughts and comments. And for the first one, thinking about estimating beta t, that is definitely something that if you want to use a log RT or log beta t model, that you have to do. And in fact, in one of our examples, yeah, so like we were able to estimate RT and beta t grid in this in the second example because it's doable from the data. But sometimes, for example, this one we are looking at school masking, and it's not that practical to estimate RT and beta t directly from the data. So instead, we're saying like there are different specifications from the least flexible or the requiring the strongest assumption going to the log growth model, which in this case is the most flexible given that we can't estimate RT and beta t. And the things is like, you need to understand, we want to highlight that you need to understand what assumptions you're making by using this particular specification. And that's something you want to report and make it clear that, okay, we're assuming, for example, equal initial conditions and why that is or can be the case in this example. And yes, and although for the thoughts about, it's hard to think about running DID for something we don't observe. I agree, that's true. And the other thing is like thinking about instance, right? A lot of time we observe cases and sometimes we need to convert it back to instance because we have different levels of reporting rate and we have different like spillovers, we have migrations. And these are also some kind of thing, if you want to run a robust model, that you need to think about how to correct for the bias that can be there. Because we are always trying to, we really observe what's true happening there. We are always sort of taking a proxy of what we are trying to model. And then to the second question about. Yeah, sorry, yeah, I talked for a while, so I stopped remembering. Okay, yeah, that's a great question. And that actually gives us back to why we started to think about this question is that, like, let's say you have something that's exponentially growing. As long as their levels are differed at one single time point, they're not going to go parallel afterwards, right? So that's just like the nature of exponential growth. But it is definitely possible to observe, like, instance going pretty like having sort of a linear structure in the sense that you have a let's say there's many infectious disease out there or other kind of decision on transmission dynamic out there that you're observing then to have something that's less punishing than exponential growth. And in that case, like you could infer from what you observe that you have some level of confidence saying that the certain parameters are the same. But in that case, like we're sort of jumping out of the framework of having a very population exponential growth model.
Can I? I think it's actually the opposite of what you say, that because you can see a disease transmission exploding, and because interventions are often implemented with transmission going up, oftentimes it is the case that trends appear parallel at the start of a time series because you're just working in very small levels. But then even if there's no intervention, it would have diverged just by the underlying process. So we would say that if you think there's any negative process, you see any difference in levels, then you should worry that even if you are parallel, they would be diverged too.
But that's my practical application. So to know how many periods pre-period do we need to see to infer how many pre-periods working. How many pre-periods do we need to see to kind of infer that yeah, parallel trends do exist, and the intervention is more quasi-random rather than selection or whatever it is. Right? So yeah, as you said, if it's a short period, you cannot infer because it might appear parallel, but it can diverge. Maybe it's a very long pre-period. Maybe we can do that inference.
We can talk about
Yeah, yeah.
All right, so we got 3 hands up. I think I'll probably get us close to the break. So, yeah. Thanks. Yeah, no, 5 minutes. So, this is great, really interesting for your presentation. And just bringing it to the economics a little bit, so I think one of the big contributions of economics during the pandemic was thinking about behavioral responses to risks, right? And I think the way that fits into this is in your beta parameter. And you're allowing data to be different between the treatment and control. And so I'm just wondering if you could help us think about how behavior might differ for a treatment and control group, and if that matters over time.
So for so thanks a lot for the question. So for behavior, you're thinking about like the two groups can, like the individuals who act differently under the sense that they have a different beta parameter.
Yeah, whatever generated.
Right. So that's something that we're thinking about. I think we have a conversation about like a theoretical effect, for example. It's like, for example, we have a world where if the beta t is greater than 1.5, then everybody is trying to stay at home because it's like over 1.5, so it's like act differently. While in the control group is below 1.5, and people will say, oh, it's still okay. And that's something, yeah, so that's something definitely could be possible happening in the world that have a different behavior. But as long as there is no intervention that changes how the transmission or how the beta parameter different from the two groups, it will be okay to do that. Because in the sense of the beta parameter, the trends will stay in parallel.
That was really interesting. I'm Nick from Hopkins. Really interesting because you know, just to interrogate these assumptions. I guess my only thought that was more of a comment is I mean, do we need to just be thinking about SAR models? I mean, this could be like anything, right? Like anything where we have I think we've been kicking the idea around quite a bit in the last few years because we've realized there are lots of issues. But you know, there are lots of times I think when we have a data generating process that's like highly nonlinear and where you might worry about this kind of thing that has nothing to do with disease spread.
Yeah, thanks for the question. And yeah, exactly to the point of that we started incorporating an SIR model because, well, it is one of the simplest yet commonly used infection disease model in practice. And in that sense, like we could easily unpack the mathematical assumptions underlying the SIR model. For example, in the instance, we could write out expression relatively easily and then solve for the condition that's required. And in that sense, that boils down to you need equal initial transmission, you need equal initial conditions, equal transmission rates, and then all kinds needs to be equal. And then that's something moving forward we were able to solve for the condition for the different specifications. But yes, the point I want to highlight here is definitely for other kind of data generating processes like this one, the very complicated malaria. Like I'm sure that they also have a set of differential equations, but instead of, for example, 3 in the SIR, they probably have 20. And that's something that would be hard if we want to solve mathematically what are the conditions for like each of the specification. But our point is that like if from a very simplest setting of the SIR that we see instance or log instance specification that are not that plausible, it is very hard for me to believe that it will somehow work very well when you have a very complicated transmission process. And the other things about, so we also have the beta T and RT, the quantities defined in our proposed specification of the two proposed specification. And in that we are using their, so they are fundamental epidemiological quantities and they're sort of part of this system. So as long as they are defined in the framework that or the transmission dynamic that you're trying to model. And you should be, then that should be a very easy transportation from what we have right now to, for example, this one here with the malaria transmission.
Yeah, good time. Hi, Jacob Norton, postdoc at Penn. I just wanted to sharpen the discussion of pre-trends. Is it a theoretical concern that we could have arbitrarily many periods of pre-trends that look exactly parallel, but we won't identify the right causal parameter? Or is it more of a practical consideration that just in practice, with these small numbers, it's hard to detect pre-trends in these failures?
Yeah, that's a great question. I think it's a little bit of a mix of the theoretical and the practical considerations, like in a theoretical or in a mathematical sense, right? That's the graphs are what we expect to see, but that's not always what we observe in the real world. For example, one that might appear misleading is like, as the conversation just mentioned, like when you're at the start of the epidemic, the caseloads are relatively low, so they will appear to be growing in parallel. But the fact is that if you continue to monitor it, they will grow divergent afterward. So yes, I think it's a combination of using what happens when we are expecting it to growing up, but we're seeing something different. Like you need to be aware that might be just part of like that exploding up just not happening yet, and be cautious of what exactly the underlying assumptions you are putting into there to believe that what you observe will continue to be the truth.
Individual already, like,